excitingly, it's a fun time of year for everybody. Hopefully, everyone gets to see family, get some time to do some great things. What is our theme for this winter one, Prithvi?
Uh,
Do you remember?
bloody Christmas, or no. Be careful what you wish for.
Holiday surprises.
Oh,
My
holiday.
God, come on.
Got it. Got
Literally had a conversation about this whole thing. This is nice to
it.
remember.
So Neil, where'd you
I
get that suit?
It is a part of the COBRA Institute line of appropriate wear
Mandatory.
for
Yeah, they were that.
some
Nice.
They were that
mandatory outfit.
Right.
This was a gift. We have an annual. Sumit and I throw a ugly sweater party, and which someone got me the blue suit. Sumit already had the red suit, so there you are. And then you guys will see Alex. There's Alex right behind me. In the whole thing. So it was the biggest party of the yet. I think there were like 85 people with ugly sweaters. My child is the Rena is the we had like 9 or 10 prizes for the best outfits and some great winners. I think we got like a quorum. I think Kelly, are you here from Bausch? Do you want to say hi? You do, you that's great. If you don't, that's
I
okay.
I know I am. Hi, thanks everyone. I appreciate. I didn't wear a ugly Christmas sweater. I could go get my light up one. My kid has my Home Alone one. So, no, thanks for
Good
letting
one.
us join. I am gonna put in the chat here later, so the information about our Air Fellows program, and I'll do that later on.
Awesome. Fantastic. So
Thank
the
you.
Bausch
Yeah.
Fellows program coming in a bit. Thanks for your support as always, Kelly and the whole Bausch crew. I think the Stanford crew is starting. Is that right?
I think we are, yeah. A bunch of people are going to be retina specialists. Congratulations to those of you who are listening that went through the process, survived, matched. The future is bright and safe, which is really great.
Bright
So why don't we
and
get
safe or just bright? I don't
safe,
know if you're safe
safe and
or
bright?
bright.
Yeah.
Okay.
Is your outfit from Figs or is that your own? Right. Our first,
Again, in the
our
chat, you'll be able to buy this one. I'll sell it. I'm putting on
love
auction and I will donate the
it.
money to the
Love it.
Prithvi Mruthyunjaya Professorship of Ophthalmology.
My sweater fun. So we have a potpourri of cases today, which I think are going to be lots of discussion that we can come from. So our first presenter is Jonathan Lin. Jonathan is one of our first year fellows here at Stanford and did his residency at Mass Eye and Ear. And he is going to take us through maybe a slightly controversial case. I'm not sure, but a lot to learn nonetheless. Jonathan, you on?
Yes, I'm here. Let me share my screen.
Sure.
And you want to swap your displays if you don't mind.
Yes. Do that. Okay.
It's usually the Cole fellows that do this. Now ours are doing it.
Actually,
Hey,
it's actually never us.
son, take it
Actually, it's never
back.
us. It's surprising how often the Stanford fellows do this. It's impressive.
All right. Hopefully now you can see the right screen.
Looks good.
Perfect. Great. So I'm excited to share this this case with you all and hear the exciting discussion. This is a case that I did with Dr. Bembalakanda. All right. So this case is a 55-year-old female who presented to the retina clinic with decreased vision in both eyes for 1 month. She'd been following in the retina clinic, pretty regularly up until about 2021, and she presented to the clinic with kind of these complaints and wanted to reestablish care. She had a history of non-proliferative diabetic retinopathy with diabetic macular edema and had previously been receiving anti-VEGF, relatively sporadically. But the last time she was here was 2021. She was a glaucoma suspect. She had a phaco IOL in 2021. Notably, in terms of her systemic problems, she also has end-stage renal disease, status post-renal renal transplant in 2022 on a few immunosuppressive medications, as well as cirrhosis, and is currently on the liver transplant list. So on presentation to the clinic, she had hand motion vision in the right eye, 2150 in the left eye. Otherwise, pupils, IOP, EOMs were normal. Anterior segment was largely unremarkable. PCIOL in the right eye, as we had previously talked about, and very mild cataract in the left eye. And then when looking at the posterior pole, you can see clearly this is not a healthy retina. So in the right eye, a lot of granular white changes in the periphery with numerous areas that look like likely breaks with kind of moth-eaten appearance and kind of total retinal detachment in the right eye. In the left eye, you can see a similar pattern of scattered granular retinal whitening in the periphery, though the retina appears attached at this stage. And so at this point, we had a very high concern for viral retinitis, given the history of immunocompromise, particularly CMV, for example. Also in our differential, we worried about acute retinal necrosis, HSV, VZV type patterns. And so the plan at this point was to give the patient intravitreal ganciclovir, and then to send the patient to the ER. This was the day before Thanksgiving. And so to send the patient to the Stanford ER for planning surgery, as well as getting input from our infectious disease colleagues, given the kind of the medical complexity here.
So Jonathan, both eyes look terrible. And was there any other workup done? And which eye are you targeting? Is it just the right because of the worse vision, or where do you go with this?
Yeah, great question. So the kind of extensive systemic workup was initiated once the patient got this. Part of the reason why she was sent to the emergency room to kind of coordinate this care. And so we pretty rapidly got various systemic labs. So looking for example, CMV, viremia, checking. Obviously this patient has a history of immunosuppression given her medication list, but obviously want to make sure she doesn't have HIV/AIDS. So that was also sent. Along with various other infectious, RPR, TB, those kinds of things to verify. In terms of the surgical plan, so I think initially the plan was to address the detachment and hopes that in terms of the viral retinitis, local administration of in the other eye and left eye, as well as systemic antiviral. So she was started on IV ganciclovir when she got to the ER. So the thought was that hopefully that antiviral therapy would help address at least partially the issues. So that the initial plan was to start with there, and then depending on how the workup panned out, like consider intervening in the left eye, depending on what the underlying etiology appeared to be.
Before we get to the case, Neil, we waited 3 years in COBRA to show a uveitis case. I was hoping it would go another 3 years before we had to.
All cases are uveitis until proven otherwise.
Don't remind me. So in terms of timing, is this an urgency? Like, do you forsake your Thanksgiving dinner for getting this patient to the ER in a total detachment right eye, left eye? Like, how long do you need to wait for the medicines to work? Guide us.
Yeah. So we actually. Oh, go ahead.
I was going to say, I don't know if that was the right answer. I was just curious, what was the pressure of the patient? Was the pressure low?
Pressure was normal, actually. I mean, let me have the numbers here.
Yeah, I mean, I think one of the things I always remind, it's relatively low to the other eye is, on these cases, these are challenging cases to do, number one, even in the ideal scenario. Number two, with active retinitis, it becomes very, very difficult. There's often an exudative component to active retinitis that makes it look worse. So you think you have regmatogenous, but you actually have a combination. So starting the treatment actually can improve some of the aspects of the detachment. And usually these eyes have been not seeing for a little bit of time. So to get some area of the retinitis inactive often will help you, but it can take a while for the retinitis to become inactive. So I think when you see detachment, I tell people just first make sure it is truly regmatogenous, make sure it's not, there isn't a component exudative, try to treat some of the retinitis. But for me, this is fixed within a week. This is not a fix within a day. That's at least for me. I'd get some antivirals on board and schedule it. I wouldn't do it urgently.
Jonathan, what was your thought when you guys were running through it?
Yeah, I think we did it pretty urgently. We did the next day. So I think the thought was to try to address.
No wrong answer. I mean, I don't think no one would ever fault you for fixing a detachment sooner. I mean, I think this is it's a hard case. And the antivirals, I think, on board just make it a little bit easier. It doesn't always mean it will be easier, but it makes it a little bit easier.
Jonathan, what are you guys thinking about in terms of surgical approach? Besides the pseudophakic eye, are you thinking buccal vit here or just vitrectomy?
Yeah, so this is a pseudophakic eye. We were kind kind of thinking that, so you can see in the picture here that there's this large kind of break that looks quite posterior. And so, I think the initial thought was that we might be able to get away without a buckle in this context. I know that might be controversial, but we did not plan for a buckle going into this case. And we thought that.
Yeah, I think you have to be careful on this. This is a young patient, and you can easily be fooled on these cases. And I think actually for the vast majority of these cases, I put a buckle on, or at least have a buckle on, because the hyaloid is incredibly adherent, and it's really hard to get this. So the buckle buys you a little bit of protection. So, and I just be careful with saying I could get away with a vitrectomy, because there's an implication in that language that it's not ideal. I think you're going to try to fix it. I don't think you guys are trying to get away with anything, right? But these are hard cases, and I just think that more is better in sometimes these kind of cases to protect yourself. But there are plenty of case reports or case series on vitrectomies for these that have just as good of outcomes as buccal vit. So let's see what happens.
Daniil, are you thinking going in, this is automatically an oil eye?
Yeah, I think these are hard to fix with gas. I have a 4-quadrant retinitis. The detachment rate is 100%. 4-quadrant retinitis, the hypotony rate is incredibly high. So oil, yeah.
Does it change any of your pharmacologic management post-operative if you're going to continue to give intravitreals?
No, I just put it right in. Doesn't change anything for me.
Carolyn, are you thinking retinectomy when you see this eye, or maybe not?
No, I want to try and save as much of the retina as possible. So it really depends on like Sunil said, like status of the hyaloid, how much you can get up, how close you can shave, how clean you can get it. I also lean towards putting a buckle on these eyes, also because they get like CMV a little less so, but like the ARN patients, it's so inflammatory. They got a lot of like scarring, and they get anterior loop PVR and all this bad stuff. So I like putting buckles on these. Just gives me a little extra reassurance or peace of mind.
Jonathan, why don't you show us what you did?
Sounds good.
We're ready to see this tough case here.
Yeah, these are hard. Hopefully, did you do this I hope you did it, in the morning or not in the evening.
Yes, this was the first time
with a really good team of people, with you, because these are just hard cases in general.
Well, it sounds like
And
it was the day before Thanksgiving. So then it's like before turkey, after turkey.
So this was that the patient came the day before Thanksgiving, and this surgery was on the day of Thanksgiving in the morning before dinner.
Before dinner. There you go.
Pre-prandial.
All right, here we go. And so initial plan was to also do, get some vitreous samples, because we weren't, 100% sure what was going on here. So you can see we're doing a 25 gauge setup, putting the infusion, obviously not turning it on, so to make sure we can get a good undiluted vitreous sample. So going in, you can see there's quite a bit of, dense vitritis. You can see those areas of kind of granular whitening in the periphery. So that's our undiluted sample. Here's where we're getting a semi-dilute sample after starting the infusion. And the plan, here was now to kind of gently remove the vitreous. As it has been alluded to, the vitreous, the hyaloid was extremely sticky to the retina, so you can see quite a bit of mobility. I think it does look highly mobile here, partially, also because it's quite a bit sped up, but we did experience quite a bit of movement of the retina here.
What were you doing
to try to pause?
counter?
Go ahead.
What were you doing to counter that jumpiness?
Yeah, so I think being very cautious with the aspiration rate on the foot pedal, and kind of being very gentle to balance the. I think in this case we didn't switch to it, the mobile retina mode or anything in particular, but I think being very cognizant, that would have been one option. Being cognizant, one consideration that we didn't do at the time would be obviously to put fluorocarbon liquid in the eye to help stabilize. I mean, not this stage, but later on, once you had some of the vitreous removed to stabilize the retina. We did not end up doing that, but that would be one option.
Did you already give the patient? Your patient got 1 dose of intravitreal ganciclovir and had already received a dose of IV at this point?
That's correct. Yeah. So the patient went. Yeah, to the ER. Like, they showed up to the clinic and
Yeah.
during the day on Wednesday, got systemic, local intravitreals, and then went to the ER the same day, got systemic antivirals, and this was done the next day.
That's great.
Did the
I
patient
tell
have-
you. Oh, go ahead, Karen.
I was gonna say the patient, she's asked post kidney transplant, but she has normal kidney function. Was there a discussion with ID about like renal dosing for her ganciclovir? And then was there concern about like how effective the dosage was to get in the eye?
Yeah, exactly. Yeah, very good. Yeah, definitely. So her kidney function actually was okay. Like, I mean, it wasn't perfect, but the dose of the ganciclovir was adjusted for her renal dosing based on her kidney function.
Yeah, you think on these, for surgically, I put in very quickly some triamcinolone, even in an actively infected eye, because I know I'm going to treat them with antivirals. But there's so much hyaloidal schisis in these eyes, and this is something that's going to be the biggest challenge is, ensuring that all the membranes are off. So I get in there with the triamcinolone as soon as you can, just to kind of identify and then reuse it, and then wash it out at the end. But you're still going to give them intravitreal ganciclovir or IV antivirals. So I don't really worry about the effect of the triamcinolone in these kind of cases.
So continuing the gentle lifting of the hyaloid, I've obviously omitted some of this arduous process of gently removing as much hyaloid as possible.
That is such ischemic retina.
Yeah,
Very,
the
very
nerve doesn't look.
unhappy.
They have to be cautious with the nerve on these as well. So I tend to turn down the infusion pressure on these, and because the nerve the nerve is the reason why patients don't see and who have viral retinitis, and so you have to be really, really careful. You can see the nerve is already like poorly perfused. So I turn down my pressure as low as possible.
So you can start to see kind of, especially as we're depressing, that there's a lot of kind of areas of like very moth-eaten retina and very unhealthy necrotic retina. And so, we're very trying to be as gentle as possible to not accidentally take more retina than we'd want to, but again, trying to get kind of the hyaloid off as well as possible.
Can I point out something that's going well here is that Jonathan's out in the periphery. It's detached retina. It's very easy to, when you're starting out as a first year, you have the cutter port pointing towards your lens, and the vitreous is underneath you, and you have this prayer going on that the vitreous is magically going to come into your port. And I think what Jonathan's doing is he's being a little aggressive, and he's kind of turning himself into that cut edge. And I think with some of these, tough detachments, you're balancing the line between being aggressive, maybe making a little break, but you're getting the vitreous off. But I think there's a lot of inefficiency that can happen with just waiting for the vitreous to magically come into your port rather than like going to it. And I think that's something that we all have to learn to do that. But it's tough because it's bouncy. And that's where, again, maybe perfluorocarbon could have been a little less bouncy, but you still had to be as aggressive with the direction.
So, as Dr. Srivastava alluded to, we put some catalog into the eye to make sure we help visualize the vitreous. Fortunately, posterior vitreous attachment had already occurred in this patient. I think that would have been a big challenge to try to induce in this case. So at this point, we were pretty happy with how the removal of the vitreous, and so now we're using endodiathermy to mark these various breaks.
Yeah, there's like a whole bunch of breaks here. Like, why not just connect them?
Yeah.
If you connect them, then yeah, it's gonna hard to know where to flag things out, but a lot of breaks.
Yeah, I think our thought was to try to preserve as much. I mean, this patient already has lost a lot of retina to the disease process, and trying to preserve as much viable retina as we can to give the patient the best kind of possible visual potential.
I'd say that when you're in this scenario, especially in bioretinitis, when you have 3 to 4 quadrants of breaks, it's either a 360 or it's a buckle. Like, it is very hard for this thing to flatten. So I think if you were at this point and you don't do a 360, it's fine not to, but I would have put a buckle on, at this point, because there's so much anterior traction that comes from these. So freeing it, to Prithvi's point, I think he was trying to lead you down a path with this question, gives you an opportunity to not have to put a buckle on. And you're right, try to save the real estate. If you're saving the real estate, you also have to recognize the real estate has some negative impact. And that's where I think the buckle might have helped you here.
Got it.
Even though, Sunil, so to clarify that, even though, this looks mobile and he's going to get it flat, you can go to air and it'll flatten, he'll put oil in, you're still concerned about that anterior retina causing all the trouble.
Absolutely. And then the inferior aspect of this, I think, is also the other problem. You see how much inferior pathology there is. So I think, in general, these are challenging. And so, you could even make an argument to do an inferior 180, in this scenario, that would not be unreasonable. But I think if you're going to cut retina, in this case, you're probably going to do 360. Yeah. So I would put the buckle on just to see if I could, in my mind, putting the buckle on spares the anterior retina. That gives me a little bit more space on this.
And you wouldn't do laser, like a PRP pattern anterior to all this posterior breaks if you're not putting a buckle on.
At some point in time, you can keep lasering until you laser the macula. So no. Let's let him keep going. Sorry, man.
All good.
Prithvi, what would that purpose serve?
Nothing. I was just asking.
Okay.
I think that it's all ischemic and ratty tissue anyway. So I mean, if you thought you could kind of make it die so that it doesn't release any badness, but.
So the plan was to, as Dr. Srivastava alluded to, to put silicone oil, and so we did an inferior peripheral iridotomy here, using laser initially to help kind of cauterize the iris tissues to minimize bleeding. And then we went to air.
You, Jonathan, just like
Sure.
show of hands, just everyone being honest. Who does the PIs still? Does everyone remember to do the PIs?
Yeah.
Oh, good for you guys.
Yeah, I did the PI.
I did the PI if they're aphakic. Like if this is like a long-standing pseudofake, I don't feel like I have to do a PI.
I don't see the utility in a pseudofake.
Yeah,
I'm with you guys. I don't do them unless they're.
Oh, I thought in general, not in an intact pseudofake. Oh, I wouldn't do.
This patient's pseudofaking, right, Jonathan?
Yeah.
Yes.
Oh.
Yeah.
No right or wrong answer.
Yeah, we're just saying that it might be optional in a pseudofake, but in a afake, I think we would all, want to get a nice big PI in there. I like the laser though. That's a neat one. I haven't done that before.
Well, the fellow tries to make a small PI, and then you get like 4 quadrant PI. So
Iris resection.
So going to air here, draining from that posterior break, and then applying endolaser. One of the challenges we had during this was that because of the kind of the areas of necrotic retina and kind of unhealthy retina, there were some areas that were more challenging to get good uptake, and so that was one kind of limitation or one challenge during this part of the case.
I say that this is where, when you have this much retina in a laser, the performance does help too. Just being able to do it, so you can get a really good idea where what's retinitis and what's break, and so you can see it better, I think, than seeing it under air. But you're saving yourself the PFO complications or challenges with it. But I think you just made this a little harder for yourself.
So injecting silicone oil at this point, and then closing up shop. So the patient had received ganciclovir the day prior, but because we just removed a bunch of the vitreous, we re-injected the patient with ganciclovir at this point. And and along with the normal subconjugate antibiotic and steroid. All right, so going back.
Nice job.
So
You got it
thank
flat. Let's see if it stays
Also-
flat.
Yeah. So over the course of the next few days, some of the laboratory tests that we had ordered returned. And so somewhat unsurprisingly, the aqueous humor tap that was done in clinic prior to sending the patient to the ER was positive for CMV. The plasma DNA was positive for CMV, and as well as the vitreous samples. Some of the other tests that we had ordered are syphilis, toxo, HIV, the vitreous HSV, BZV, the vitreous bacterial culture and Gram-Sin all were negative nor normal. So the patient, this is still kind of an ongoing story because this happened pretty relatively recently, but the patient at post-op week 1 remained flat under oil, vision of counting fingers. Unfortunately, shortly thereafter in the left eye, she was found to be developed a detachment in the other eye. This is pretty high risk, and so the patient has, at this point undergone surgery in the left eye as well. But I think this was kind of a really I think a challenging case, but also kind of taught me a lot about how some of the fundamentals really become magnified, the importance of them become magnified, and when the conditions are not optimal.
I think you did a great job.
That's good.
That's great.
Do you guys know about compassionate use of Vitrasert? I hear you can still get it in this country, like on a compassionate use basis. Is that true?
They stopped making it
Oh, they made
a
it.
dozen years ago. So
I remember.
I don't know what you're getting.
How do you get
you're
it?
getting an empty pellet.
I heard they were getting at UCSF sometimes, so I'm curious.
I
Well,
thought you were
that-
with me on the case at UCLA where we put one in the one eye and then we went to
Yeah.
schedule the other eye and we couldn't order it because they were like, you got the last one. There's no more.
Yeah.
Based on
And that
dose-
was when out as a fellow.
Bausch hasn't made one in over a decade. So yeah, I mean,
I wouldn't give your personal credit card to that source.
Yeah, I can get you one. I have one sitting on my desk. I don't know if it's filled with anything.
Yeah, it would be nice, I guess. But all right, good stuff.
Nice. So up for us is Joe Abraham. Joe is one of our first-year fellows. Joe did his residency here at Cleveland Clinic, and he's going to show us a challenging macro hole case, I believe. Is that correct, Joe? Joe, I hope you're talking.
Joe, mute.
Joe?
You're muted, buddy.
Okay, there we go. It was just causing me some different.
Okay,
have-
so like
you have a
remember
voice
Joe, I
on.
said before that the Cleveland Clinic people don't make these mistakes. Do you remember literally
All
how
right, it was a
happened?
different mistake. Can we just point that out?
So
All
I'm
right,
looking
so-
for a new first-year fellow, by the way. Just so anyone know, I was just like,
I'm looking for a new
Go for
fellow, just if there's anyone else out there.
Oh.
All right, so we have a 60-year-old female. She presents with recurrent macular hole after 9 months after appeal. It was closed at the prior visit at post-op month 3. So this is what it looks like. So patient's vision was 2100, pseudophakic, obviously status post-vit here. So we have this recurrent hole, and there's obviously multiple strategies on how to go about doing the second.
Were you involved in that first one?
No,
Do we know like how wide the ILM peel was? They didn't use any flaps or flips or anything.
no flap. The peel was, and you can see it kind of on after I stain. The peel was fairly broad.
It almost looks like
I
there's a
can-
little RM.
I can speak to that.
over here. So
Alex Yoon's on who did the case. Alex.
Hello. Yes, so the first case, it was a pretty broad peel, extending almost to the arcades, and probably like 1.5 to 2 disc diameters from the hole. And sorry, what was your other question about the first case?
The flap. And we
No
didn't do flap.
inverted flaps. Yeah, just a regular peel. Nothing out of the ordinary with the first case. Would actually a good question here, would in a post in a patient a failed macular hole with this appearance, would anyone do anything else before taking the patient to surgery?
So Alex, did the patient have like cataract surgery between like your surgery, or was they were already pseudophakic, or
We made
Yes.
patient pseudophakic the first case.
first case? So the fact that the patient now has, opened a hole, I mean, this makes you curious whether or not what happened. Could it have been like macular edema that occurred that then popped this hole open? I've done like some topical steroids on cases like that, and just to see if it could do something. And I think I've had one case where I closed, but for the most part, I think you're going back in.
Yeah. And I think for the patient also, like, you've taken them for one surgery and then, it didn't work in your hands for whatever, like, late reason. So I can understand the
Yeah.
need to try to be definitive.
Yeah, I don't know if I do Ferris a fluid exchange in the office, but I mean, I think I just take him to the OR if I was going to do something beyond topical.
We tried the topicals, and actually I did try to inject a gas bubble and have the patient positioned, but it failed.
All right, Alex did everything that was recommended. I like it. Anybody else want to write something in the chat? Alex probably did it.
I agree with Asan and Carolyn. I mean, I don't think there's any harm to starting the drops in the interim, but this hole is like more open, and the flaps are more elevated than typically the ones that I've seen sort of close with treating with drops. So I think I'm planning to go back to the OR, but doing drops doesn't hurt at all in the interim.
So Joe, there's nothing reported on techniques for recurrent macular holes. So you probably figured something out on this one because no one has an opinion on how to fix these now.
Go for it, Joe. Keep hitting play. Let's move forward if you don't mind.
All right, so we're starting here.
Sorry if I missed this. Did this eye have a good visual potential?
The vision was before it reopened. I think at that post-op month 3 visit, it was like 20/40.
Okay. Oh,
And there were 2100 at this visit, right? When they were open.
After the recurrence.
Is that good enough, Asan, or is that like, do you give up at that point?
I'm just saying that OCT, I'm curious if we didn't, prognosticate more. That doesn't look like a good OCT to me. So I'm worried about how we're going to close that readily and probably have to use other techniques like Prithvi alluded to that ultimately don't really give you much vision back. So I'm going to be curious to see how this goes.
Let's see what happens.
All right, so I thought I deleted this. Oh, that's fine. Okay, so we're staining with ICG.
And what was your mental plan here, Joe, at this point, with the ICG stain? Can you walk us through what you were thinking?
We just
or
wanted
what you
to,
and Alex were talking.
Yeah, of course. We wanted to confirm that we had a sufficient peel of the ILM around the fovea there. And so, to this ICG would give.
Well, I guess walk us through. So like if there was a good enough peel, if there wasn't a good enough peel, was that it? You're going to be done? Or if there wasn't a good enough peel, then you're going to do other steps. Is that kind of your
exactly
your decision?
So
okay.
If there was and if anything like seemed very amenable to peeling that was left, just to take it and try to minimize any possible residual traction that might be opening this up a little bit.
All right, let's see.
And so,
coming up with all the potential possibilities on the chat.
So you can see there's a pretty decently broad peel there. It's about 1.5 to 2 disc diameters beyond the fovea there, and nearly to the arcades. So we did decide to, and the view wasn't great for making this flap here, but we did decide to take some more of that ILM here because of that issue of any residual traction opening up the hole here. And so this is a key point here.
So I think the view was good, but there might be.
I meant just on the video. The video itself, it didn't come out well for just that part. So that is going to be replayed. if anyone caught that. I had a deep grab there, and you can see that there's a just there. Yeah, you can see that deep grab. And so we're planning on doing a subretinal bleb here. So we'll see the results of that here shortly.
Oh, so that was
So Joe,
intentional.
before you go forward, I have a pause for a second. Go ahead, Alex. You're going to say something.
So Joe, did you want to mention what the surgical planning was and why in this case? You revealed that we were thinking surgical bleb. Why were we thinking bleb, versus like an inverted flap or
So the flap, I feel like it would have been hard with the peel that we already have to get it sufficiently over. The bleb versus the amniotic membrane were kind of the two options there outside of that main ones. And I know that we'd discussed earlier why you prefer to do the blebs, but now it escapes me.
So again, Joe, I guess I'm going to ask why do the peeling if you're going to do the, I mean, the peel is so far away from the hole. Did you think that was all the traction there? I mean, I guess you have the deep grab, sure, but I guess I'd go back and say, well, why were you peeling it? In that scenario.
So I think that like I mentioned, that if there was any residual traction from that remaining ILM there was and it seemed like it would be relatively easy ILM to get as well. It was, it was coming fairly cleanly, except for that unfortunate moment there.
So
That's the whole point.
Actually,
Go
there
ahead.
was a little bit of ERM there too. If you look, I can't really see it with the flat lens
Oh,
here.
I believe you. Yeah.
But
okay.
yeah, there was a little bit of ERM,
Yeah.
so that's why, I wanted to really peel that a little further, just in case that ERM was putting too much tension temporally there.
So I think it was in the chat. So when you have a deep grab, what did you do next? Did you shoot the pressure up? Did you, how did you, so it was bleeding a little bit, what do you do when you have a deep grab?
So in this case, since it kind of released almost immediately, and it wasn't causing a lot of bleeding, I think we put the pressure up very briefly, but then continued on
Gotcha.
because
Okay.
it was fairly stable. And just peeling a
Joe,
little
what
bit.
forcep are you using here? Just curious.
I believe those were the max grips.
Yeah.
No,
So the
ILM forceps.
nope, those are the Vortex.
Oh
The
yeah.
Vortex
The
adaptive.
adaptive, yeah.
So here, still trying to make sure we get off any residual ILM, ERM. It was kind of hard from the, it was very vertical with my right hand there. And the visualization wasn't very good, so we decided to restain.
Also, Joe, why do you think you had a deep grab there?
I think part of it was probably related to that verticality and adjusting to assessing the depth when it's in that orientation. I'm still personally getting used to. So I didn't realize I was quite as deep, obviously, as I was.
Yes. I think when you're so vertical in that location, you really can't see where you're grabbing. So you gotta really think about maybe readjusting and starting somewhere else in these cases. It's tempting to just kind of go for what is most obvious, but sometimes you gotta think about your hand position too, because you could block your own visualization.
Yeah, I think the other thing I'd tell you is that if you look at what you were grabbing at, it was actually ILM that had flipped over and you went down to kind of grab at it and you were trying to grab a piece and we went down and grabbed the flap over. So it's like it's a little more slippery, if you will, and you think you're at one tissue plane, but you're actually at a deeper one. It's harder for you to see. So something to be aware of when you're grabbing that flipped over eye line. It's actually easier to whack into the retina at that point.
It's, yeah, I guess I didn't realize that. In my mind, I'm like, if it's flipped over, it's almost like an easier.
Yeah, if you're coming at it from one edge, but you were going straight down over it. So if you were going at it like on the flipped edge and like grabbing, on top of it, but you were going down deep on it. So that's how it happens. So it's just, you'll do that hopefully less. But as you get more experience, you'll recognize the difference.
Hopefully, yes.
To all of our first year fellows and residents who just matched, peeling is part technical, but a lot of it's mental as well, and it's so easy to, I think, get in your head, when something's not quite going right. So it's always great if that's happening to like take a minute, breathe. Restaining is like a nice opportunity to just sort of like reset. So, I know that you did that for the visualization, but also just for sort of resetting, it can be really helpful as well.
And I forgot to mention, I think this is Joe's like what, maybe like second peel, third peel, right?
Yeah, it like maybe certainly within the first 5.
I mean, great job for what you're doing so far. I mean, you're staying calm, right? So, we don't want to be too harsh on you.
No, we're not. No one's being harsh. I think just these are learning opportunities of why things occur, right? If we were being harsh, I mean, Prithvi would be yelling.
I would be. I'm enjoying this.
So we're about to finish with this peeling. About to, I promise.
Yeah, no, and Joe, the other thing is, as you're getting further out, like if it's a myopic eye, then the eye curves a little bit. So there's some decision that needs to be made, for the macular surgeon, when is enough, right? So maybe you've gone far enough, and then you can kind of decide if that's the if you need to do any more. You're probably good where you are.
Yeah, and this is where we stopped. So I just had a question for the group here. So, obviously we know we have that deep grab. The surgical plan was to do a bleb. Where would you guys start the bleb in this case relative to the fovea / the area of the deep grab?
Pat, you're like a bleb maker.
I usually do, if I'm doing blebs, I usually do 3. I usually do inferior, superiorly, and temporally. So obviously I would stay away from the area where you had the deep grab because it's just going to be harder to see your landmark. So I'd probably start inferior, superiorly. If I already and when I do my temporal one, I would just kind of stay away from that area. If you already have a little bit of bleb around there, you can sort of go in a bleb already. And then at the end, I try and use the Tano to just kind of massage the hole a little bit so the edges are kind of freed up.
Let's see what you guys did.
So we went a different approach. First couple of blebs here with Dr. Ewan, and then I do the last one. So initially decided to try going in the area of the grab itself because we were concerned about fluid egressing from the area there. It wasn't really taking well, so went to the strategy that
Alex, question to Alex, does it really matter if the fluid, first off, that's like quite a ways away, from the area around the hole. And even if the fluid did egress, I mean, the purpose of the blebs is to break up any subretinal adhesions that will prevent the hole from coming together. So if it lifts it up around the hole and then it all comes out there later, it's going to come out tomorrow anyways when it gets pumped out. So I'm not sure I'd be that worried about having to manage the side hole. That's kind of what I'm thinking.
I think in hindsight,
egress,
go ahead, Joe.
It seemingly wasn't getting to the hole from when we were initially creating the blebs. Like it was like you can see here, the fluid margin doesn't quite reach the hole there.
So the initial decision, I thought, oh, there's already deep grab. I'm just gonna try to go through the same hole. And instead of making a new hole, let's just try to use that hole to bleb. But I think the deep grab was a little too big, and it didn't give me enough of a seal around the cannula to form a nice bleb. So that's why that one had to be abandoned. And then we, you know, you can see here, we ended up going in inferior instead.
Yeah, round volcano would be great. I don't think they make that in 25 gauge anymore.
Asan is going to buy one with the Vitrasert.
Hey, you got a good
how,
one there. Let's
Kat,
see.
how far from the hole do you need?
Hold on. Joe's doing his. Let's see Joe do his. Yeah, let's see Joe do his.
A moment to shine.
Come on, let him go. Let's see it.
Go, Joe. Oh,
there you go.
Well,
nice.
beautiful.
I actually think he did the best
Beautiful,
one.
Joe.
Yeah,
Yeah, that's awesome.
The
It's
location.
really challenging.
better than Alex. That's so
Well,
good.
it's the person pushing the fluid, so Alex gets all the credit.
That is a good point. So, you know, Joe, like, what were you like? How were you pushing? Was this like automated? Were you on the foot pedal?
Actually, I can't take credit for it. Yeah, Joe, you want to tell him how?
It was with the foot pedal. So I just before when I was very close to the retina, I started the flow and then slowly went in, quite tentatively, but eventually it went in.
I think that's key. Like you're dripping right before you get there, and then suddenly it'll come forward. That's key.
Nice job. That was good.
And yeah, so now we could see that there was that little bit of fluid. Trying to be maybe a bit greedy there with trying to get a bit more, but decided that was sufficient. And we have
I find sometimes on the air fluid exchange it moves into the space. So I don't know if you have to be that aggressive with the diamond. I think it has a tendency to move into the space with the air
okay,
fluid.
it'll move more posterior with the air.
Back in the day of macular translocation is the air fluid exchange with peripheral detachment that allowed the posterior to detach.
Yep.
And this is our post-op month 1 visit. There's still gas, so the hole is closed. Vision is still not great, but there's a lot of gas still in the eye.
That's great.
And it looks like the deep grab is closed. Nice job. Woo.
So
or at least you didn't OCT it, so it's fine.
And you know, I have a case or two that has like an ectopic macular hole, like you know, the central one's closed and there may be another one off to the side. I don't think you know, you're not creating such trauma, and if the bleeding is controlled, it's not going to like proliferate through. I think it's recognizing it as a fellow that okay, there is a deep grab, you don't continue, controlling bleeding, and then you know you move on, and usually right around that area is another place to grab. So I think you let go fast, which is the key. So it was really well done.
Yeah, it was good work preventing a secondary problem, and good blebs. Nice work. And I think more vision coming because the EZ looks like it's doing okay there. And just for everyone who doesn't know Alex, behind my picture, that's Alex right there. There's Santa. Just for everyone to see.
That's how he usually looks.
That's his beard all the time.
Yeah, super job with peeling.
All right.
Very good.
Nice work, Joe.
Moving along, talking about secondary problems, we have Jared Sokol, who's one of our second year. Jared, very nice, very nice. Our resident AI graphics dude. Jared's finishing with us this year, and he's going to talk to us about a lens case. I like this one, Jared. This is one of your better ones.
Yeah, this one's. Oh, thank you. And the title of our talk is Naughty or Nice.
I get it.
Yes.
No one else does. I get it.
No one else does. But all right, so this is a 79-year-old male referred to the retina clinic. 2 months prior, he had a complicated cataract surgery with PC rupture and vitreous loss. A one piece during that surgery was initially placed, but it was noted to be malposition, so it was cut and removed. And then a 3-piece was inserted, but during this insertion, the trailing haptic broke off, And during attempted removal of the IOL, it was dropped through the posterior rupture and into the posterior segment.
This is like the worst nightmare of every
Yeah.
cataract surgeon.
The literal worst nightmare for a cataract surgeon. And this was
What a
outside, so
disaster.
you know they weren't at our like a Cole or a Byers where you have a retina doc operating next door. So they closed up shop and referred it to us.
That's probably the best thing. I mean, honestly, you know, at some level, you know, the patient's probably under topical. It's already nerve-wracking for everyone. It's the probably best just to close. I'm
Yeah.
curious, was the wound sutured when they came to you?
Yes. The wound was-
Awesome.
well,
that's the best thing. Holy
I
cow,
think
that's a
so.
win.
Let's
That's a
look at the
win.
video actually. Now that you we'll look at the video. So when the patient presented, well, it was actually 2 months after the case, so maybe they already removed the suture. But the patient was 2,500 in the right eye. There was severe defold with diffuse corneal edema, and the retina was attached, but you had the dislocated IOL and the vitreous. So this was 2 months after presentation.
2 months? Wow.
Yeah,
Okay.
that cornea is like
2
So-
months of severe default? Wow.
Yeah.
That's a miss. That's a
So the cornea is pretty toast here. So that kind of leads us to what do we do? What do we have to think about here? So you know, the general plan was do a vitrectomy, remove the broken and dislocated IOL, and place a secondary IOL. But the cornea here has persistent corneal edema, and we need to think about what's going to happen down the line. They're probably going to need an endothelial keratoplasty. And an important aspect of endothelial keratoplasty is that often air or SF6 gas is placed. So that's something that you really have to think about when doing secondary IOLs. So the Acryos is kind of my go-to, but again, there are reports of the Acryos opacifying from gas, from air, or from silicone oil. And there's reports of it opacifying from air and gas for a DMEC as well. So Acryos is definitely not the way to go here for risk of opacification. You know, ACIOL with a likely corneal transplant down the road would not be great. I don't think the cornea surgeons want to be grafting under an ACIOL. And you know, I don't think it would be an ideal situation here with the.
Hey, Jared, were you guys planning on combo surgery or stage surgery?
We were going to do a combo surgery here.
Okay.
Yeah, we were going to do
I mean,
it all.
you could make an argument for a stage, right? Doing the corneal surgery first to make it easier for you to see, and then you would have the option for your Acryos.
Well, no. We planned stage, meaning we would go first, and then the cornea transplant would be after.
But
Okay.
by the time we
Yeah.
waited long enough for the cornea to clear up a little
Yeah.
enough that we could do the surgery,
I
knowing
see.
that
Okay.
knowing that we're going to make the cornea worse with our surgery, and knowing that this patient's almost certainly going to need a dissect.
Yeah, I've done these similarly, Steve. Like, you know, I've had the same scenario, and I've had the cornea surgeons kind of go first, and then let the eye clear up, and then you've done my part. But you know, either way works. You know, I think you have options for each.
Yeah,
I think for the cornea sake, it's better if you can do the surgery through whatever the old cornea, because anything you do to that dissect, any surgery after that dissect is going to damage endothelial cells, and it's going to be more likely to fail it at an earlier time period. So if you can get it done through the cornea, it's better. But there are cases where the cornea doesn't get clear enough to do it safely, in which case, like you said, you have to have the dissect first and then do your surgery.
And the last thing you want during COBRA rounds is dislocating endothelial graft.
exactly.
Definitely.
And I didn't say this was with Dr. Steven Sanislow, who joins us now. Okay, so ACIOL was kind of out, given the need for likely corneal surgery. So then we were between a Yamane and an Envista. You know, I think a Yamane would be fine here, but I don't know. I've had some luck and some not luck with Yamanes. I've had it tilt mid-surgery and had to take it out and do an Acryos. So I'm more excited about 4 points fixation personally. So we decided to go with an Envista here. And just something important to think about is if you're doing surgery before a dissect, you need to aim more myopic because the dissect will give you a hyperopic shift. So we aimed like -1.5 here.
I think that's a really good point. Now people remember. Good point. Good thing to bring up.
Yeah. So this is the peak of my digital animation in PowerPoint career. So here's an Invista lens. We have it in the correct orientation, just like any other lens. Actually, how we approach these is we actually cut off the haptics because the haptics aren't doing a lot for us. We're not having it be suspended in the capsular bag. They're not, distributing tension in the capsular bag. Honestly, they just can kind of get in the way. So we actually cut off the haptics of these Invistas here. And then we string the Gore-Tex. So just something important in an Invista is that you have to string them opposite. And what opposite means is that, you have two sections of this loop. On one side, the Gore-Tex has to be going under one side of the loop and out the other. And on the other side, it has to be going in and out of the other side of the loop. And this is so when you suspend it in, it doesn't flip. If you put the Gore-Tex both on the same side of the loop, once it was in the eye, it would then turn. So it's just important to make sure you have the Gore-Tex correctly, and one is on one side of the loop and one's on the other side of the loop.
One other point about cutting off the haptics is it's kind of nicer because you don't get loops of a suture going around the haptics that you don't in a position that you don't want them when you're putting the lens in, because that's always an issue I find with the Invista is if you're not careful, you can get the lens inside and have one suture looped around the haptic, and it's kind of difficult. You can do it, but it's difficult to do that once it's in the eye to get all that off. So if you cut the haptics, you often don't have to deal with that problem.
Exactly.
That cornea looks awful.
When we started this case, I said to Dr. Stanislaw, like, "Are you sure?" He was like, "Yeah, let's do it." I'm like, "Okay." So we decided to proceed. So we did our focal, nasal, and temporal peritomies here. And then we marked here, we marked 275 back from our limbus. And then I believe we did 4 wide.
I think it was 3, but either way.
3, okay. Putting in our infusion, checking. And when we put our trocars in for the Invista acroleus, we want it non-beveled.
Steve, you stopped doing the horizontally displaced sclerotomies? I thought you were doing that for a while. I've heard some other people have good success with that. Can you comment on that?
Horizontally displaced sclerotomies?
Like you put it closer
like
to the
radial?
pars plana in the same plane.
Oh, radially. I mostly don't do those because I just worry about you're not locking the lens because then everything is radial, and it seems to me the lens could wiggle on that axis. And so if the person's playing basketball or something, that lens could be bouncing, hitting their iris and stuff like that. Whereas if you do the circumferential sutures, you are actually locking it because of the way that the sutures were placed. When you squeeze those, it's going to lock it in place and keep it from spinning. Whereas if you put radial through the 2 eye holes and you squeeze it, it doesn't really give you much support for the lens not spinning on its axis. It actually doesn't if you just put sutures through those holes and hold it. It doesn't, but it's theoretically could be an issue. But the radial ones are definitely easier to do, much easier.
So here we just did the vitrectomy and was freeing the IOL from the inferior vitreous. The view was actually shockingly good given how bad that cornea looked. You can see it kind of looks like a little Pac-Man lens. So I think the cataract surgeon attempted to cut the lens, and there was actually no haptics at all on the lens. So I don't know if both were taken off. We did end up scraping the cornea to improve our visualization. So we then entered the anterior chamber with the keratome blade and expanded with the crescent blade. And again, it's easier to take a lens out when it has no haptics and a quarter it was already gone. But we did end up.
I think it's just important to make sure that none of the lens is in the back part of the eye,
Yeah,
you know?
definitely.
Like even if you get like report from the person who did the surgery, you know, like trust but verify. You know, people are anxious and they don't know exactly what happened sometimes.
I feel like
I actually called the surgeon personally ahead of this case because her report had said the haptic broke off, but then didn't say anything else. Like, was it still in there or not? And so I talked to her and she said yes, she had removed them. So
Okay.
yeah, because I was concerned about that as well, Kate. Kat.
Yeah, it's helpful to have that. I mean, you know, oftentimes I feel like in academic centers we get sent these people without any history and then you're figuring it out, you know.
I wanted to give Sumit a shout out. Like sometimes we learn things on these meetings too. I switched my IOL cutter to that. What is that called? The Gills Welsh or something? You guys use that Cole? That thing is clutch. I love that scissor. That's what I use for all of our IOL removals. Now, Jared, you used it with me in the OR recently too.
yeah, that thing's great. It's big, but it works fast.
A nice long platform just slides right in and cuts it really smoothly. That was, I think,
those are great.
Yeah.
One sec. So we're stringing the Gore-Tex in just like an acroleos, superior nasal going into the superior nasal sclerotomy and so on and so forth. Just making sure not to cross ourselves or anything like that, and making sure we're staying nice and neat. And then I like to fold the lens with a cyclodialysis spatula. You could also use another McPherson. There's also different forceps that kind of
Hey,
fold.
Jared, can you pause for a second?
Yes.
Before you go any further? I'm just curious how many people put all 4 in for this, or I tend to put 2 in. I'll put the nasal one in, and then for this lens in particular, because I'm so concerned about like the orientation. I'm just curious to what other people do.
Yeah,
I just
I
do
did a nasal.
2. Yeah, sorry.
I like 4.
You put it in 4. Yeah, and Kat, what do you put 2 in?
I do
I always
2
go
and
nasal
then
side. Yeah.
I always do my left side first and then I do my right side, like regardless of the eye. I'm just used to
But
the
how come you
optics
don't
or
how
how
come
that
you don't put
looks.
3 or 4 in like everybody else? Is it because you're
I'm worried it's gonna start twisting because with
Yeah.
this one, it can start to like rotate really easily, and then once the visual cues that you're used to change, it's hard to know. So you could go 360 without realizing it. So that's why I just
Yeah.
did the 2. I tightened my first side so that my second haptic is like in the center of my view, and then I do that side.
I learned that from Kat. I've started doing that. I tie the nasal side down 3 and then pull that, like, with the smooth, pull that loop up while I put in the lens. So I think that works really nicely.
The key thing I've learned, especially for the fellows, that where you start getting entanglement and twisting is it all has to do with how you release the lens in the eye. So whatever direction you fold it, you actually need to go back counter that way when you're opening it in the eye. And I think that's where fellows sometimes panic because you start opening it, the lens is opening up, and then everything starts rapidly twisting. So however you put it in, you rotate your hand counterclockwise back that same orientation, and your lens will be flat.
Yeah. Sunil, I think that's a valid point about with the Invista, and that's one of the reasons I like to have the haptics taken off.
Yeah.
With the acroleos, I find if you're very meticulous about how your sutures all go into the eye, the order, making sure nothing's crossed, it doesn't matter how you insert the lens. You could flip the lens 5 times. As long as you push it deep and dunk it deep when you go in, it will self-right. You just start, and I've seen it. You're pulling on the thing, the thing just flips right around.
Well,
and
yeah, that's because you have
it's
4
always
points.
imperfect. Yeah,
Yeah.
with
Yeah, I agree.
So with the
Yeah.
acroleos, I always do 4. With this one, I do. It depends, but yeah.
Yeah, no, I was speaking specific about the MX60, but yeah, I agree with you. Makes sense. Keep going, bro.
All right. So I messed something up here. Try to catch it. Here's our holiday surprise.
Did you throw 3 on the one on the left?
We are actually just doing a two.
Gotcha.
I do a 2-1-1 because the knot is
2-1-1.
smaller and you don't need that tension. So I don't know why people do 3 on the first one. But maybe this will tell.
I do 3 for my first knot, not because you need it, but I rotate that knot down and then I use it to occlude my superior sclerotomies, and I just find that that helps plug a little bit. I mean, I'm sure 2 is probably fine as well, but I just like having that extra bulk to it. I think that helps.
Is that temporal knot a little unraveled?
Well,
So on the temporal
on the
knot,
right, you did a 2-1-1. I
Yes.
missed the you presented the VR round. I missed this one, but when I watched your video this morning,
so on
on
the
the right, you did a
nasal,
2-1-1.
I
Yeah,
only
on
did
your
a
nasal.
2-1 accidentally.
Oh, you did a 2-1. Okay.
And it's been cut.
And it's been cut.
Nice.
So get ready for some fun.
I didn't catch it, unfortunately.
At least it's not that 8-0 Gore-Tex that you love, Jared.
Came apart.
Or a 9-0 Proline.
I think one of the
So-
other faculty members on this call had this recent complication as well, right?
We were gonna show it, and then we realized we were having the exact same thing. So it's like we can't do this twice.
So
Too
as we
painful.
saw it unraveled before our eyes, so we were like, crap, we could tie it with 2 max grips. We could not tie it with 2 max grips. So what we ended up deciding to do is we decided to try to tie more Gore-Tex on the end of one of the tiny ends and then rotate that in and tie it to the larger the larger end of the Gore-Tex. So we kind of twisted around in a 2 and tied it there.
I hope it works.
Basically, you're just using it to thread the new longer suture in.
Exactly. So we have this little
This is
end.
where my Boy Scout knot tying skills come in handy. It's not
So then-
easy to tie a loose suture to another one.
So
But
we rotated that in, and then we were, just starting fresh now. And then we did carefully a 2-1-1-1.
we rotated the knot all the way out, right? Where we connected the 2.
Well, we put that back in the eye.
Why
So
wouldn't
this
you
is-
just pull it all the way through?
This
I
is
think we
fret.
did.
You did, right?
No, it
No.
didn't look like that. Looked like
You
you
just left it in the eye. Why
We
wouldn't
just
you
left
just
it in
pull it
the
all the
eye.
way through?
Because we were afraid that if that
Oh, I
knot
know.
were to go all the way around, then I think we were afraid it could break the little Invista haptic, because the
That's
knot
possible.
that whole thing would have to go through the little eyelet. And then you would have to put tension to pull it out the other side, and it
but
may
when you
open the knot.
rotate, you're like just hoping that you measured enough that when you rotate this knot, the other knot doesn't come out,
Yes.
right? Like you only have
Yeah,
a few
it didn't.
millimeters. Yeah, I mean, you're lucky, but
Because then we rotate this back in a little. Yeah, exactly.
When was this case, Jared?
Maybe 5 months ago.
I'm looking forward to the late dislocation in the ear.
Ouch.
This is a rough Stanford crowd. It's usually the
Seriously.
cold trauma. It's the Stanford.
Yeah,
and
exactly.
Stanford
We were so
trauma
nice to
tonight.
each other, Kat. It's nice.
No, it's a
I
slick,
know.
slick technique to rescue it, though. I just want to try to, but yeah, it's tough.
I think I
You
would
gotta
have tried to
potentially
pull
with
it
fracture.
through, but you're right. Because if that didn't work, then you're rethreading it anyways, right? Like
Right.
you kind of bought that for yourself, but it's very good.
Yeah, the biggest problem though is if you are having to pull too hard and you cheese wire, then you don't get a late dislocation. You get it the next morning, which I've had once, and it's not fun to talk to the patient when you've cheese wired through this thing.
Yeah.
Yeah, I think that's a
Great
good thing
job.
to know about the Envista. Like you can pull through that eyelet really easily. So I always tell our fellows, like, you want to really err on the side of keeping it loose. Like you'd rather have it too loose than too tight, for sure.
Absolutely.
So post-op month 1, the patient was 2150, lens was centered, cornea was very edematous. The patient got a dissect, then the dissect detached, then they did a dissect repositioning with a repeat bubble. And then 2 months after the dissect repositioning, the cornea was clear. His old glasses gave him 20/70, pinhole 20/50, and with refraction, he was 20/30.
Nice job.
That's
Yeah.
pretty
Nice
good.
work.
And the lens is
work.
holding strong.
Which eye was that? Was that the right eye?
That was the right eye. So he had a bunch of irregular astigmatism, which I feel like we get a
That's
lot
the
of
dissect. That's a cornea guy's fault, though. It's
Definitely.
not your fault.
Definitely.
There's
Also got
nothing to
some
do with it.
prisms there.
Yeah,
Some prism
exactly.
Yeah, I didn't do
situation
that.
there.
It's only one. That's awesome. That's
But I
great.
mean, spherical equivalent, you end up getting around a -2, which is what you're aiming
Yeah.
for.
Right.
Like,
That's
Exactly.
great. Nice job. Good work.
Nice.
All right. Thanks.
All right. Our final speaker is Rachel Downs. Rachel, I'm happy to announce, has just signed to join us here at the clinic. She's
Yay.
newest faculty member. Thank you. Thanks for joining us, Rachel. And
You
Rachel's
will
got
never leave the COBRA fold.
Thank you.
yeah,
Thank you.
COBRA forever. We got her a free tattoo as part of her.
He's gonna yell at us more than anyone else next year.
Yeah, exactly. This is
That's
true. She's gonna be the hardest on all of them. Take it away, Rachel. What are you gonna show us?
So I'm going to show you a case that's going to make some people question why they wanted me to be employed at the Cole Eye Institute for at least a few moments. So just bear with me. For my holiday surprise, you can see Jared and I are seasoned second years. We're not afraid to show some real mistakes. I call this all's well that ends well. So I'm just showing my trocar placement really so that I have time to set the scene, which is that I was operating with Dr. Srivastava toward the end of my first year. We were having an amazing day. We were getting through like 6, 7 cases. Everyone was happy. The day was running great. This is our last case, buccal vit on a high myope. And as I'm passing the last suture, it's immediately evident that I had perfed. There's egress of fluid out of the wound. So what I'm showing is us getting into the eye sort of as quickly as we can and seeing something that I hope to never see again, which is a huge submacular hemorrhage emanating from my perforation site.
You can stop for a second. So let me ask the faculty here.
Yeah.
You know, your fellow says like perfed. What do you guys? What's it? Just after quietly screaming in your head, but showing incredible. What do you do next?
Is the needle still in the eye, or is the suture is the needle passed and the suture's there? Like, where are we right now, Rachel?
I think it was your first pass into it, wasn't it?
Of
Rachel?
that quad, I think it was my first pass in that quadrant.
Yeah.
but
So
the
then
needle,
you
you
know-
already went through, like you went through and through, or
Yeah.
the needle
yes,
is like still
yeah.
in the sclera.
It was
and
it was
The needle's out of the sclera.
But the
okay,
suture's
but
in.
the suture's in, and you use nylon or use Merceline.
nylon.
Okay. Well, I think the reason why I think Prithvi was asking that is like, if it was a braided suture, I don't like pulling it through when it's perfed. I like leaving it in and then just immediately like pushing on the eyeball to keep the pressure up to minimize the bleeding. Oftentimes the fellow's like, oh crap, and they like pull it. And then that braided suture, it's like friction, and then I don't know what's happening. And there's like more friction, more bleeding. So I leave it alone, and then I'm just like pulling on my strings, putting Q-tips in, pushing on the eyeball, keeping the pressure while I'm like telling, if it was a planned combined case and your vitrectors are already in the room, but if it was a primary buckle and you're like, go get the machine, bring it in the room, like while you're just holding pressure and trying to keep the bleed from becoming a ginormous bleed.
So
And then if the needle's still in, I'll back out. I don't keep going through, obviously.
And then do you just inject fluid quickly on like a TB30 gauge, or would you put the infusion in if you're doing a combined case, or?
I would look in first, right? I'd get the indirect, and I'd take a look, because maybe this isn't happening. You know, sometimes if the suture comes through, you can actually see the suture in the subretinal space, and you know, like all these scenarios could be going on. If it's very small and localized, you could put pressure on it for a little bit longer, and then watch to see what you have, and then decide if you need to go in or not. If it's a deep pass, You may still be able to continue your case. You may re-insufflate the eye as you're talking about with some fluid, and still continue with the buckle. Versus, if you see this, then you may need to change your approach.
All right, go for it. Yeah, so we lifted the strings, put Q-tips. We were both worried, so we're like, we're getting in right now.
Yeah, this was a planned combo in this case. So fortunately we had everything ready to go. So verifying that the hyaloid is up and proceeding with our vitrectomy. So at this point, I'm just like trying to stay calm and do my job.
You can see your perf
were very
site there.
calm.
You can see your perf site right there in this superior view.
Yeah. Putting in PFO.
Actually, that's not the perf site. So that view that where you're looking at, that's not the perf site. The perf site is
Yeah.
it's more nasal.
Nasal is that tail that's trickling down that's causing.
Yeah, exactly. Yeah.
So Rachel, what's your can you talk us through what you're thinking about here? Like, how are you going to address this blood? Like, is this like one small hole and drain it? Are you going to make an inferior retinectomy? How much blood do you need to get out? What's your thought?
Yeah. So I think our first thought was put in some PFO. Maybe we'll be able to get some of the blood to displace just as we're going about our vit with that PFO down. And then we made a plan pretty quickly to do subretinal TPA to try to address sort of the clotting and allow for more of the blood to mobilize in the postoperative period. So we immediately asked our staff to get moving on that, which at Cleveland Clinic involves a call to the pharmacy, arranging for TPA. And this OCT was part of our plan for that. Dr. Srivastava and I were talking at the time about sort of assessing the height of it and feeling like we had obviously space to insert a subretinal cannula and place that TPA.
So why don't you pause here for a second? So that was our plan. I guess let me ask Stanford Group, what would my colleagues there do? Would you go with a retinectomy and try to evacuate it, or just
we
leave
still
it?
have a retinal detachment? That's why we're here, right?
Mm-hmm.
And where's the detachment now, other than where the blood is? Was this can you describe the detachment initially?
Yeah, it was a MAC-off, pretty bullous detachment and a high myope.
Okay, so
and what was the causative break?
We'll get to that. We actually didn't.
Yeah. We didn't find it. We think it's nasal. I think in the end of this, but it was a pseudophakic detachment.
So blood under a detachment eye, not ideal, right? So PVR risk goes high. I would look to evacuate this. I don't think this is a displacement scenario as much as getting that blood out. That's a fair amount of blood. And even if that displaces, the worst thing that could happen is that you had a break at 6 o'clock and all this blood is now soaking around a 6 o'clock break. So at this point, I think you have to think about, and Carolyn asked the right question, where is your break? Can you use that to your advantage to kind of create a larger space to get access to the subretinal space? And if not, then doing a limited retinectomy in order to access it, to aspirate it out, I think would be the next step. And you don't have to do a inferior 180 or a 360. I mean, you could even actually, in this case, do a superior 90 or a superior, a couple clock hours, just enough that you can get your soft tip in to remove the blood and potentially a clot. I'm not sure. I think you could probably do all that before at least our pharmacy would find the TPA and get it back to us in time.
So do you find, we talked about this at Cole a bit, do you find that when you have a clot, you end up taking some RP with you if you try to remove it?
This is, unlike a chronic subretinal hemorrhage, this is pretty fresh. So I don't think that you have this congealed clot that's sticking to the RPE. It's possible, but I think that even if you reflux into the subretinal space, for example, and you mobilize that blood, I don't think in a matter of minutes it's going to become a dense, hard rubber clot. It's still going to be soft enough. And even if you were to grab on it, you made a large reflecting retinectomy and you grabbed it with a forceps, you're not grabbing down onto the RP, you're just on the surface of it. But I think you could probably get a lot of this out with just some form of fluid and aspiration.
And you would use like your standard soft tip for that?
Standard soft tip, yeah.
Can I make a
All right,
comment
let's see what you
about?
did. Yeah.
Can I make a comment
Go for-
about the removal of submacular hemorrhage? So I think she's alluding to the issues back in the day when submacular hemorrhages were, would be removed surgically by grabbing the clot and pulling them out. And obviously that wasn't very helpful to patients. And some of the thoughts was more, not that it was adherent to the RPE, but that it was intertwined within the photoreceptors and that you were pulling out photoreceptors. And so that's probably more of the concern than pulling out RPE. But as Prithvi said, in an acute clot, I don't think you have to worry about that.
I still think that that can occur if you. I mean, we've all done the diabetics where they bleed and they get this like fibrinoid material that happens relatively quickly. So that's always my concern with doing a retinectomy and flipping and trying to grab. I do think there is a risk, but let's see what happens and we'll go from there. Let's just go for it.
Okay. So we're taking a look at our perf site. There's still some hemorrhage going on there. We're closing up one of our trocars, our supratemporal trocar, so that we can insert a 23 gauge.
Did you abandon the buckle idea?
The buckle's still on. We finished the buckle.
Okay, good.
So we're unable to find a break. So this is us making our drainage retinotomy on the buckle. Some of that blood aspirated out through that retinotomy, as you saw, but not a really meaningful amount. Taking down our PFO and then preparing our 42 gauge cannula by cutting it to create a sharp bevel and refluxing some TPA outside of the eye. And then putting some TPA subretinally.
Nice blood.
Thank you. Nice assistant pushing the plunge on me. And now we're going to air.
How long did we sit and wait?
We waited 20 minutes. We set a timer, stopped everything, and waited 20 minutes. Which
just let the TPA sit there while I was sitting there watching it.
Yeah. Our very kind, overworked OR staff was very gracious with us.
Are you doing a full FAX here or like 70, 80%? What are you doing?
We did a full and then we put in C3F8.
Yeah, you can make an argument for doing like a 90%. I think that was I didn't have her like tap down and like really try to remove every little bit. So we probably removed 95% of it. There was a little bit of fluid, but it wasn't a lot. But your point is well taken. Can you just use it, so that you have at least somewhere that the blood moves to and you can squeegee it out. So I didn't do that. We did a full one, but yeah, it's a fair point.
How do you position immediately and like PACU, and then when they go home, what are you guys doing?
We went right to face down.
No, remember she sat. So no, she actually
we
sat.
did it. You're right. We had her in the
sat.
reading. We had her in the reading man position. So we had her sitting up 45 degrees down.
Yeah. So first thing we did was I kept her face up until we got to PACU for another like 10, 15 minutes. And then she went into the thinking person position and then slowly kind of came up.
So then just in terms of for fellows who haven't seen this or people on the call who haven't seen this before, what to expect on post-op day one. These patients, when you see them on post-op day one, are going to have a hyphema. They are going to have a hemorrhage if there's any like fluid phase in the vitreous cavity. So that's just like something to expect and know that you're going to see. You may have to do some active pressure management. So in this case for our patient, by the time we were planning to take her back 6 weeks later, she had cleared most of the hyphema. There was still a little bit of blood in the anterior chamber. She had some gas in the back, as you'll see, and then a lot of vitreous hemorrhage that had not cleared. So we wanted to take her back and clear her out and just take stock of what was going on. The retina had been looking flat on ultrasounds in the clinic. So here we are quickly on that repeat case. So evacuating the remaining C3F8 gas. And washing out the AC to address the remaining hyphema.
Starting to look like an eyeball.
Mm-hmm. And going in to look in the back of the eye. So at this point, we were feeling pleased to see that there was no longer subretinal blood, at least under the fovea. Most of it had been nicely displaced inferiorly. So we just continued with our depressed shave, cleaning up any remaining gel that was still there after our first case. We did a fluid air exchange and just left her under air at this point. OCT of the affected area was actually looking pretty good. We're pleased with that contour.
So Neil, why did you do the second surgery if things were clearing up?
Oh, she had like just this non-clearing vitreous hemorrhage and a hyphema. And I just felt like the blood was going to take a while. And I was just like, I need to see what this retina looks like, honestly. Just, I could have waited longer,
yeah.
but it wasn't clearing, and I probably could have waited a little longer, but Rachel was still on rotation. I can't remember who was on rotation.
It was my last day on the rotation.
Maybe it was like, I think you need to see this before this is done.
I'm actually surprised you waited that long. I don't know if I would have had the stomach to wait that long. But it seems like you waited that long. Maybe you could wait longer and maybe you wouldn't have to go back.
It's fair. I've had 2 other cases like this in the past, decade or so. And, I didn't have to go in for the other 2. And it cleared, and we had a hyphema and such, but I was able to see through and the blood cleared. This was probably the large. Adi had one a couple of years ago, and it was just as large of a clot. That one, we didn't have to go in, but this one, I felt like things were going to go fine, but once it didn't clear at like 1 month, I was like, okay, let's just go and get it.
So Rachel, this is a happy ending to this story. You have a buckle, a lot of that blood was inferior and temporal. You could have, the alternative is that on the buckle, make a retinectomy temporal, right? So that, because you made your drainage retinotomy nasal, I think.
Nasal, yeah.
Yeah, nasal. So you could do a straight temporal, keep it above 8 o'clock, a couple of clock hours, enough so that you can then get your soft tip in and see if that, could have evacuated that blood. I think like back in the day, like when, it was a straight buckle and there was a massive, subretinal hemorrhage from a deep needle, that's kind of where we went. It wasn't, try to get the buckle on and then make a retinectomy and drain it. But this, you showed me otherwise, so it's good.
So just another question about the soft tip. Like, do you find that if you're going in and your entry site is on the buckle, how do you get that posterior enough to get?
So sometimes not easy. If the blood is still mobile because it's relatively fresh, you could do a combination of a active infusion, let it swirl around a little bit, and then it'll come out. If it's like a clot, then that's harder. Then you need to make a larger retinectomy in order to be able to reflect the retina to get into that subretinal space to suck it out like as a clunk. So sometimes, you have to, sometimes we've made a inferior 180, because
like birthing a baby, it always causes a tear.
Yeah.
But the clot's always bigger.
Yeah, I think that the thing that you have to be careful on is that, you have subretinal hemorrhage and then you make a pretty large retinectomy and you have blood. And even though if it's superior and temporal and you can support it, you have a large break now with blood. And Prithvi won't tell you the other side of those stories was those were all PVR cases.
Yeah.
That you did later.
Then on the flip side of it is that you have a retinal detachment and a myope and you have subretinal blood, right? Like, so you're kind of caught in both ways. Like you're caught.
So I think the point point of showing this is that it's, we made one small additional part, right? We put a hole in the macular area, but this was able to displace the blood without having to make a large retinectomy. Sorry, Caroline, you were saying
Yeah, I was
something.
gonna say, like, I haven't used a snake since like the 20 gauge days. Do they make small gauge snakes? No, right? So like I remember in residency and even like first year fellowship, when that happened, we would get the snake out, but we were using 20 gauge vitrectomy still back then. Like there was 23, there was 25, but they're all non-valved, and like you're still thinking about fluidics and all of that. So yeah, I like what you did. I think it's smart, it makes sense, and you didn't have to cut a ginormous hole in the retina that would get stretched even bigger as you birth this ginormous clot. So kudos.
Yes, I think more, Rachel, you were calm, even though you were questioning lots of things, and it's hard to know what to do in those scenarios. I think knowing that we had TPA available, and again, as I said, that this was this has happened to me a couple times now that I've done this. And I've been pleased with how these turn out. So a technique to do and try for those if you're put in the scenario, have to call for the TPA as soon as you see it, because it takes 20, at least it takes for us 20 minutes to get. So
I think Jared made a really good point when he asked about fluid. Sometimes when you're doing a buckle, a straight buckle, many of us will keep a syringe of BSS, on the field. So in case something happens, they're not trying to draw it up at that moment. You can like pop it in and go from there. That's a good idea.
Yeah. Well, another great.
Can I add a note to just the Stanford people? So we're not in the hospital like you guys, or that close to the hospital like you guys are to get TPA, but we do have TPA in our clinic. So you could have it brought down from the clinic, although you'll have to mix it yourself or in the OR. But I do like this TPA choice here, Sunil, and I would definitely do that in the future.
I think another. I just again, I hope this never happens to any of you, and if it does, just a potential technique. There was a comment on the chat about where to put the bleb. We went temporal macula, and we used OCT to kind of see where it was pooling. But you could, I think, if you went just temporally and you put it into the space, it's going to absorb into that whole space and mix, as long as you keep the patient supine for a while. So we just went temporal macula where it was easy to kind of get into the space.
Yeah.
All right.
Very good.
We survived another year of COBRA. Congratulations.
Thank you to our fellows for showing difficult cases and showing us how they got in and out of some trouble. It's not easy to share some of these tough cases in front of everybody. So a round of applause for all of the fellows for doing a great job, and to our mentors who continue to stimulate us with quirky comments, but also really smart comments too. So we appreciate you guys a lot. For all of you that tuned in, and to our iVista team that keep us going, and to Bausch for continuing to support us. And Sunil, are we going to do this again?
We are. I don't know if we picked another date yet. We are doing it, I believe, at end of February or early March of 2025. Thanks everyone for joining us, and have a great holiday.
Happy holidays.